Good evening, everyone, and welcome to today's What's on Your Heart panel, hosted by Tallahassee Memorial Healthcare. February is Heart Month, so in honor of that, our expert panel of heart doctors will be answering your questions about heart health and discussing some of the common heart issues impacting our community. I'm Trish Karowski, and I'll be your moderator for tonight's program. Before we begin, please join me in welcoming our esteemed panel, all members of our region's leading heart team at Tallahassee Memorial Healthcare and Southern Medical Group. Today, we're joined by Dr. Patrick Murrah. Dr. Murrah is a cardiothoracic surgeon trained in advanced robotic surgery. He's also a member of TMH's structural heart team. We're also joined by Dr. Pablo Rengifo Moreno, an interventional cardiologist and co-chair of TMH's structural heart program. Please also welcome cardiologist and cardiac imaging specialist, Dr. Gregory Hartledge. Dr. Hartledge also specializes in cardio-oncology. Thank you all for being here today.
Thank you.
Thank you.
Thank you.
Many of our viewers submitted questions in advance, so I'll be sharing those questions with the doctors as we go along. But if you have additional questions, submit those via the question and answer feature in Zoom, and I will get those to the doctors as much in real time as I possibly can. Okay, so we got a lot of heart to cover here, so let's not waste any time. Let's get right to it. Dr. Rengifo, let me start with you. It feels like most people know somebody who has died from heart disease. I believe it's the #1 killer in the United States. Why is that?
Well, it all boils down to risk factors. And so if you think about the United States, the percentage of population that had overweight or obesity is almost 70%. When you think about hypertension, 1 in 2 Americans have hypertension. Hypercholesterolemia is 2 out of 5 on the population. Some risk factors have been modified or have been decreasing over time. Smokers are approximately 10% of the population. Diabetics is 10% of the population. Sedentary life, 25% of the population. So we do have a lot of work to do in decreasing the percentage of these risk factors in the general population of the United States.
Dr. Hartledge, what are some of the most common heart conditions you see here in the Big Bend, and why do you think they're so prevalent here?
We see a lot of coronary heart disease. That's probably the leading cardiac specific condition, meaning something that actually relates to the heart. There are other things like high blood pressure that can affect the heart, but in terms of a specific condition related to the heart, coronary artery disease is the most prevalent, and is one of the most prevalent in the whole United States and the Western world. And is
when you say coronary artery disease, we're talking about clogged veins, is that?
Clogged arteries, yeah, the arteries of the heart that supply blood to the heart muscle that help it get its nutrition and essentially beat healthily. Blockages in the arteries of the heart cause the muscle to get starved, and that can cause chest pain, or angina is the term we use. And sometimes angina is the classic sort of textbook tightness in the chest, but it can be particularly in women, particularly in elderly, in people with diabetes. They can have all kinds of different symptoms: shortness of breath, or nausea, or lightheadedness, or things like that. Or some people can even be asymptomatic with it. But the heart muscle can become permanently damaged if you have a big heart attack and enough heart muscle dies, that your heart can become weak, and then you can have heart failure. Heart failure is sort of the final common pathway of all heart conditions. Heart attacks, if you have big heart attacks or multiple blockages in arteries and the heart muscle becomes weak, that can cause heart failure. Heart valve diseases, which is another common thing we see, that is either a narrowing of a valve or a leaky valve, that can cause heart failure. Heart arrhythmias can cause heart failure. Untreated high blood pressure can cause heart failure. So there's a lot of overlap in these things.
And it sounds to me like there's a lot of well, we'll talk about this later, but there are things we can do to minimize this. Dr.
Absolutely.
McCullough, what signs might indicate when someone has a heart condition? I know we talked about a few just a minute ago, but
Yeah, the lights just went out in my room, which is a pretty good sign there. And it's my turn. Really, as a cardiac surgeon, when I see people, the things we think about are are things changing, new shortness of breath, a change in your functional capacity, chest pain that changes, it comes on with less exertion, maybe it starts to come at rest. But those are, and then other signs you can have, swelling in the periphery of your extremities, but shortness of breath, chest pain, swelling in your extremities. But Greg was very thorough. Dr. Hartledge was very thorough in that prior answer. It can be very subtle, especially in women. You can see atypical patterns of chest pain. And I think a good doctor has a very high index of suspicion and always thinking that way. And you also have to take into account a good history, the importance of a good history. Do they have a positive family history? That's a big driver with patients.
okay, Dr. Hartledge, then would you recommend people go in for a baseline, or
Lights.
how would you decide when someone needs to seek a cardiologist? Seek out the cardiologist.
So I think a lot of it starts with the primary care doctors. They're probably the most important people in the community that help get patients appropriately to cardiologists. And that's who we rely on to pick up a lot of these things in the office. When people come in with sort of non-specific complaints or come in for their annual screening, physical exam kind of stuff, when they have their EKGs, which are often done in a routine manner, when their primary care doctors take their history and sort of put the pieces together in terms of risk, family history, and all those type of things. So I think that having routine follow-up with your primary care doctor is probably the single most important thing. And then beyond that whenever you have some new type of symptom, that you let your primary care doctor know, and come in and get the appropriate workup in the primary care office. And then they, in this community, are very good at appropriately referring to us, and we do our best to get people in as quickly as possible, in order to get things checked out. And sometimes it turns out to be false alarm or nothing, and we can reassure people and they're going to be fine. And oftentimes we end up picking up things that we need to know about and need to treat.
So your primary is door number one, basically.
I would say so, yes.
And Dr. Rengifo, heart palpitations. I mean, they write songs about heart palpitations. So how do you know when heart palpitations are serious versus just a harmless little quirk or something that just happened?
Well, what you just said is very important. If you think about it, the heart in average beats 80,000 times in a day. So if you have one beat out of sync or a couple beat out of sync, it's not a major deal. However, if you're a patient that have a cardiac condition and you are experiencing palpitations, you should refer to your cardiologist, because in that setting could represent a structural problem of the heart, meaning heart failure, ischemia, which is lack of blood and oxygen in the heart muscle. I also should say that when your heart rate is above 100, so it's going above 100, and there's no particular cause, you're not in pain, you're not bleeding, you don't have a fever, you don't have a thyroid problem, etc., then that's abnormal, and you should consult with your primary care physician, who might refer you directly to a cardiologist to start workup in his office. Importantly, if you're having a heart rate that is irregular, that in and of itself is not normal. if it's the normal beat and all of a sudden you have an extra beat, that might be normal. But if your heart rate is consistently irregular, that is not normal. I think everybody should learn how to take your pulse and be familiarized to how your pulse feels, and then be able to identify when you are having an irregular or an abnormal heartbeat. But in general, palpitations are benign. But if you have multiple risk factors, if you have heart conditions, and if you are consistently above 100 beats per minute or having irregular rhythms, I think that's a good time to consult.
That's when you call the primary, and then the primary tells you to come to y'all.
Yep.
Okay, well, that's good advice. Dr. Hartledge, I know that you have, you're using some new cardiac imaging tools, and I'm wondering what some of the new advances are when you're looking at people's heart and trying to diagnose issues. Can you talk about that a little bit?
Yes, we have an array of different tests that we do. Some of them have been around for decades, and some of them have been around just a couple years. And we continue to push the envelope with the most cutting edge technology and having that available here in our community. The workhorse of cardiac imaging is echocardiography. That's ultrasound of the heart. And that is done in the office and the hospital. And it tells us pretty much everything structurally that there is to know about the heart, in terms of looking at the heart valves and the heart muscle, seeing if there's leaky valves, narrowed valves, and seeing how the heart pump is doing in terms of the strength of the pump. If people have a weak heart or that type of thing, we can also, just like the weatherman on WCTV uses, we can use Doppler to assess pressures in the heart and look at flow and those type of things. And those are the tools with Echo that help us find problems that Pablo or Pat would fix either in the cath lab or in the operating room with regards to valve abnormalities. And then for heart structure, if we have something that we need to further clarify with regards to the structure of the heart or the heart pump, if there's poor quality images on ultrasound, we have an MRI program where we can do MRIs of the heart, where we get very crystal clear images with very high resolution. We also have transesophageal echocardiography, which is where instead of putting the ultrasound probe on the chest, we can put an ultrasound probe down the throat, like an endoscopy, if you've ever had, or if anybody's ever had that done at the GI center. And we can see, because the esophagus sits right behind the heart and all the structures in the heart line up and basically without any barrier, they're very proximal to the esophagus. We can see very crystal clear images, 4 times better than with ultrasound on the heart, or I'm sorry, ultrasound on the chest. When we go down the throat, we can see down to about the size of a millimeter, like these little leaflets. If we're looking for, a tear in a leaflet or something like that of a valve that's causing a leak, we can understand the severity and mechanism of problems much more readily when we go down the throat to look at the heart. And then with regards to coronary artery imaging, like we were talking about at the beginning, looking for blockages, we have multiple different types of stress testing that we do, from just putting people on treadmills and looking at EKGs, which is considered a standard sort of stress test. And then we can do ultrasound, where we see how the heart pump looks before and after exercise to see if there's any suggestion of blood flow abnormality to the heart. And then we can also do nuclear imaging, where we can see perfusion. That means the distribution of blood flow to different areas of the heart muscle with a nuclear imaging tracer. So those are 3 different ways that we do stress testing. In addition to stress testing, we have cardiac CT, which is something that has kind of rapidly progressed, and we've had more tools developed over recent years with cardiac CT, we can actually see the arteries of the heart, much like a heart cath. We see the anatomy. It's not looking at blood flow. It's actually looking at the anatomy of the arteries, looking to see if there's plaque and if that plaque is causing a narrowing. And we can assess how severe those blockages are with something that you and I have talked about before called CTFFR, or heart flow, which is a newer thing that we've just rolled out in the last few months.
And that's an exciting tool that you're talking about there. We'll get a little more into that. Okay, this next question, I'd like to open it up to the whole group, because many people think that they need to go to a larger city to get appropriate heart care when they have a problem. And I wonder how each of you would respond to that. And what would you say to them when they're looking for someone to provide heart care? We'll start with you, Dr. Murray.
Okay, I'll start. I think that one of the great things, like we're doing tonight, you have three guys, people, they're physicians that are working together towards a common goal, educating the community. And this is how we carry out our work every day, whether it's the multidisciplinary valve clinic we do on Fridays, and we see the surgeons and the cardiologists, see them together, and we come up with one patient and multiple specialties coming to see them. So that team approach, I think, is a big deal. So I think having that advantage, I think, is one big one. So,
And that's something you don't get everywhere, right?
well, you're just not going to have that everywhere. No, you're not. It can be very disjointed if you're out of town. You have all of the people that know you and are here together to take care of things. And we're up on the latest thing. We have just a terrific structural heart program that Dr. Ringifo and Dr. Harledge and myself and many others participate in. We're very proud of it. And it's a model for teamwork, and it's a really a terrific program. It's a good example.
Oh, I'm sorry, I didn't mean to cut you off.
No,
Dr.
you're good.
What would you say?
I agree 100% with Pat. I trained with a large program in Atlanta, and I trained with a large program in Tampa, and I also was as a student affiliated with a very large academic program in Gainesville. And when it comes to things that people would leave Tallahassee for to go to Atlanta or Tampa or Gainesville, or you can put Jacksonville on the list as well, there's really nothing that they do in those towns from a surgical or structural heart standpoint that we cannot offer here. And in fact, there are some things that we offer here that they don't even offer. And there are some things that they were basically on the cutting edge of, and 5 or 10 years ago, that was research at the time. And we were involved in all of those research studies with regards to structural heart and those type of things. And as early as those programs in those big cities in Atlanta and Jacksonville and Tampa, as early as they were doing things, TMH was doing them within months of that, if not earlier than them. So there's really not much else to offer. And historically, we've been just as cutting edge as anywhere else in the Southeast, in my opinion.
That's good to know. Dr. Rengifo, what would you say to someone?
I think the most important thing is people seek care where they're going to be comfortable, and they have to be comfortable with the decision that they make. So if the decision is to go somewhere else because that's how they feel comfortable, I think that's perfectly fine. I think we're very proud of the programs we have here. I think if there's something that we don't have, we have partnerships with people that can do them. We don't do transplantation of hearts. So we have partnerships with people that do that. But if you see the three of us, I trained at the University of Miami for the last portion of my training, but I was in Columbia University, in Harvard, and I have been around. And I think the wisdom of Tallahassee Memorial and in collaboration with Stoddard Medical Group is that they're looking for specialists in every field to bring them here and create a team that has that academic flavor that you might find more in the big cities, with the local flavor. You wanna be treated by your neighbors, people you know, people you respect from the community. So I think that combination is special, and I think that's one of the important things about, if you are going to be treated by us, you should be confident that you're getting people that have been trained in the latest technology, but these are people that you might run in the street on the supermarket too.
Yeah, and to that end, there's a lot to be said for being able to go home and go to bed in your own bed at night when you're having medical issues. And,
Yes.
I mean, I think there's an emotional component there that there's some comfort to not having to go back to a hotel room at the end of a stressful day.
Yes.
That's my opinion. Okay, Dr. Renjifo, let's talk about we've talked about some risk factors, but I wonder if we can start talking about how we can prevent ending up in your offices.
So
What-
I will tell you what I tell my patients. If you're religious, God, if you're a scientist, the universe, however you want to see it, we were created to be physical entities. We were made to look for food, to run away from animals, to chase animals in order to have food. We were not made to have supermarkets and refrigerators in our houses. So we need to emulate what we were made for. We need to have physical activity in our lives, because physical activities, we were made for that. We were not made for a computer. We were not made to be sitting down all day. And that's an important fact. We were not made to have all type of food all the time. So there were seasons, and with the season, that's important. We cannot be, I had more bananas here than where I had in Venezuela, where I was raised. And we have bananas here all day, every day of the year. We have everything we want. And that, although it's very convenient, it might not be healthy. And that's just an example. So I think we need to remember how we were created, the work of evolution over many, many years in order to survive different type of adversities. We need to emulate that. So physical activity is very important. Be very aware of what you eat. Sometimes I see myself, walking, I'm not hungry. I see donuts. They always put donuts everywhere. I don't know why, but you grab one. You're not hungry. You don't need it. You're not looking for it. It's so easy. So we need to be more aware of what we're putting in our bodies, the physical activity we do. What are we drinking? And so I think if you are very conscious about that, and I battled that myself, I think this is a fight that all of us are in it together. I think that will help decreasing your risk of many of these conditions.
That's a great philosophy. I like that. Although I will say it is always chocolate season. I don't care what you say about that. It's always chocolate season. Okay, Dr. Murrah, let's get specific. What exactly, I hear about it all the time. I actually take medicine for it. What is cholesterol and why is it so important when it comes to our hearts?
First, I want to give a shout out to Pablo Rengifo, Dr. Rengifo's. That was a really fascinating answer. I enjoyed that very much. And, and if I must, it's not a fair question with cholesterol you're talking to the mechanic, the guy that turns the wrench. The cholesterol is what happens to me after 2 really hard open heart cases. And it's 10:30 and the only good place to eat is Whataburger. That's what happens to Dr. Murrah. And he gets to get that one. But I am going to defer that question to give a good answer, Dr. Hartledge, on what is exactly is cholesterol, Greg.
Fair enough. Dr. Hartledge?
Okay, well, there are different types of cholesterol. And there's the types that we eat. There's dietary cholesterol, which, in years past, you would hear about things like eggs getting a bad rap because of dietary cholesterol and high cholesterol. fatty foods, fried foods, and dairy foods and things like that have a lot of cholesterol as well. There's different types of fats that we eat that come in oils as well. Some of them are more healthy, olive oil and things like that. That's a type of cholesterol, but it's a more healthy cholesterol that can be favorable to your body. And then there's, particularly in foods that are deep fried or highly processed, you may have heard of trans fats. And trans fats are actually more toxic forms of cholesterol that people eat that can make more of a bad cholesterol profile when it comes to the other side, which is the cholesterol in our bodies. Cholesterol in our bodies is essential for life. There's in the cells, there's certain things that are made out of cholesterol, like membranes and things. It's part of our metabolism. It's part of neurons in our brain. It's part of a healthy life cycle of the cell. So we rely on cholesterol. Yes.
I'm sorry, that's the good cholesterol that they talk about in the doctor's office then?
Well, no, I'll get to that.
Oh,
I'll get to that. That's, yeah. So I'm just saying cholesterol in general is part of the building blocks of what cells use to make structures that we rely on for life. The way that cholesterol is potentially negatively implicated in our bodies and where that good and bad cholesterol come in is when it comes to arteries. Cholesterol is not supposed to be present in arteries in the heart or in arteries anywhere in the body. But as part of the process of damage and repair, or part of the process of just even otherwise healthy aging. We talked about risk factors, and there are certain types of risk factors that you can control that we call modifiable risk factors, and there are types of risk factors that you can't control, which we call non-modifiable risk factors. So your family history and your age are things that you can't control, but those have an effect on the way that cholesterol is metabolized in your body. Some people have higher cholesterol because of genetic things or family related things. And then as you age, the arteries become more susceptible to cholesterol getting deposited in the blood vessels. And then in terms of the modifiable risk factors, like high cholesterol, like high blood pressure, like smoking, like diabetes, those last three things are things that actually injure the lining of arteries. The high blood pressure can do it, smoking does it, diabetes does it. So anytime there's damage to arteries, it allows cholesterol to enter the wall and start building up. And what blockages the vast majority of the time are that cause cardiac conditions like angina, cardiac chest pain, lack of blood flow, or heart attacks is because of buildup of cholesterol. And it's those bad types of cholesterol, the LDL, which is the low density lipoprotein, and triglycerides are the two bad types that we try to keep low by medications and healthy diet and exercise and that type of thing. And then the good cholesterol is HDL, or high density lipoprotein. And the bad cholesterols basically favor more of a deposition type of mechanism in arteries, whereas the good cholesterol, like the HDL, actually can pull cholesterol out of plaque. So that's why that balance is so important. And the type of foods that we eat, like we talked about, those trans fats and those type of things, and highly processed foods and fried foods, those are the more atherogenic lipids or cholesterols. And by atherogenic, meaning they are more of the type that build cholesterol in arteries and can even lead to situations where they can rapidly evolve and the cholesterol plaques can break and clots form on them. And that's when you have a big heart attack, when a clot forms in an artery acutely. So the healthier lipids or cholesterols like olive oil and those type of things, or the fats you may find in natural foods such as avocados and things like that, those actually can help protect the arteries because they have more of they increase your HDL and help sort of pull cholesterol out of plaques and arteries, more or less.
So if I'm hearing this correctly, what I'm hearing is that it's really, if we want to do something about this, we need to look more towards whole foods and natural foods, get away from processed foods and fried foods and things like that to help reduce our risk. Is that a fair?
That's absolutely right. So we don't really use people might remember the pyramid, the triangle. I think that's a good model of kind of thinking of, because you have like a foundation that's a big broad thing, and then at the top you have this little thing that rarely every blue moon you eat, like chocolate maybe. Sorry. But what the way that I talk about diet in my office is more of a type of diet that has been actually studied and proven to reduce cardiac risk because of its favorable effect on cholesterol, and that's called the Mediterranean diet. And it's something that is not just available in the Mediterranean region. It's actually something that you can do anywhere, because all it really is a foundation of fresh fruits and vegetables, of a certain type of carbohydrate. Like instead of eating a lot of carbs that are sugar or turn into sugar very rapidly, like white bread, white rice, white potatoes, it's more of the brown carbs like whole wheat, whole grain, more of a sort of slow burn kind of thing that don't turn into fat, and don't turn into sugar, like the more white carbohydrates do, like bread and white potatoes and things like that. And then the types of fats and olive oil, type of related diet and snacks instead of the, deep fried or heavy dairy or that kind of stuff. And then lean meats, a lot of fish, because fish actually, particularly cold water fish like salmon and those type of fish, have a very healthy lipid profile in them that can help with the good cholesterol and that type of thing. So that's sort of a Mediterranean style diet. And it's what you do most of the time that matters most. I mean, people are going to have birthday parties and barbecues and celebrations and family reunions and holidays and all this stuff. So, it's not like you can never eat some of that more kind of guilty pleasure stuff, or some of the stuff that's, maybe up towards the tippy top of the pyramid. But it's what you do most of the time. So eating those more healthy things, the majority of the time, will put you in a good spot to really see the benefits.
Okay. We have a question from a viewer here. Let me get to that. If someone has familial hypercholesterolemia, what testing should be done besides getting cholesterol checked? What age should they get a calcium score done? And I'll throw that out there for y'all.
So familial hypercholesterolemia is something that is a genetic condition where people have very high levels of the bad cholesterol. And there are a few criteria that it can be diagnosed by, specifically the magnitude of the elevation of their bad cholesterol, their LDL, particularly if it's over 190 or 200. And if they have a family history of family members with high cholesterol, and particularly early onset of heart disease. There's also some physical exam findings that we can see that would suggest very high cholesterol has been there for a while. There are certain things where it can deposit in the skin and in the eyes and things like that, and things that we can see. So those are the things that would increase our suspicion for familial hypercholesterolemia. We rely on our colleagues in town that are lipidologists to help with that, because Like I said, there's a genetic component, and then there's some advanced lipid parameter things that they look at. Those are different types of lipoproteins, which are the proteins that carry cholesterol in the bloodstream, and other markers that they look at, inflammatory markers and things like that, that the lipidologists really are the experts on. So
Okay,
we have a couple of lipidologists in town as well that help with that.
Okay, I didn't mean to interrupt you, but first you would go to your primary who would know that this.
Yeah,
exists.
they would be able to diagnose familial, or they would be able to evaluate those criteria that I spoke
Okay.
of and have a very high suspicion of familial hypercholesterolemia, which there's multiple types of. And then seeing a lipidologist, that's really, these are people that have dedicated their lives to understanding lipids and lipid metabolism and genetic forms of that they would further sort of refine the diagnosis and then make an appropriate treatment strategy. Like we talked about before with other things in cardiology, there's a lot of overlap with the cholesterol piece and the heart disease piece. So that's where the question about a calcium score test came up. And the way that we determine who is most appropriate for a calcium score is actually based on a few things. It goes back to the risk factor sort of assessment issue. And then it goes back to the family history, which is very big. If you have a family history of familial hypercholesterolemia and somebody had a heart attack at a young age, that's a person that I think would definitely benefit from calcium scoring at a young age, like 5 years prior to the onset of whatever the age of the family member was that had a heart attack at a young age, something like that.
Yeah, that's good. That's a good way to. I'm glad you said that. Okay, I want to move on to medications here for a minute. Dr. Rengifo, for a long time, we talked about, we were told that taking an aspirin, a baby aspirin, every day was a good preventative measure, but now they're talking about that possibly not being appropriate anymore. And I'm wondering, can you help us clear this up? Because I don't know if I should be taking it.
So importantly, I think, first of all, we have to clarify, if you have had a heart attack or you have had a stroke, there's clear benefit of taking low dose aspirin. That is not where the controversy lately lies upon. Aspirin is used as an anti-inflammatory for pain, as an antipyretic for fever, and it also is an antiplatelet, meaning, or most small component or cells that are in our bloodstream have the, going back to what I was stating before, the actual job of the platelets is when you cut yourself, they go where the cut is and they try to create a tampon there so you don't bleed.
Mhm.
The problem is that platelets can be activated in other situations, like when the covering of the blood vessel, the inside, breaks for some reason, for stress, you name it, smokers, the platelets can attach to that area and can obstruct blood flow, and then you have a heart attack. So the belief was, well, if you take aspirin at any age, you are preventing heart attacks. The problem is that aspirin also creates upset stomachs, can create ulcers, can produce renal failure. People that have ulcers can have a bleeding, and bleeding is a major problem. We sometimes think, especially if you're not in our field, that bleeding is not such a serious problem, it can be fixed rather quickly, but in so many moments could be fatal. So many people have been placing aspirin at an early age and without even having coronary artery risk factors for prevention of strokes and heart attacks. There's a couple of studies that just came out within the last year or two that studied aspirin as for prevention, not in patients that have had heart conditions, But in order to prevent these conditions, what they found is that when they compared to not taking aspirin, there was not a significant improvement in the prevention of heart attacks and strokes. And in one of them, there was a signal towards more death in patients taking aspirin. So I don't want to say now that taking aspirin might be incorrect. It has to be individualized. It has to be explained to the patient. And it's a decision that has to be made between the physician and the patient after everything is explored. If you have very high risk, even though you don't have a heart attack, you might be somebody in which your physician might consider to put you on a baby aspirin, an 81 milligram dose of aspirin. But that has to be taken into account, and the risk needs to be very well explained.
Because there are side effects that can be.
Yeah, specifically in elderly patients, and you have erosion of your gastric mucosa that can lead to ulcerations and bleeding. You have acute renal failure, which is a major problem in people taking non-steroidal anti-inflammatory medications.
Okay.
Can I make an additional comment?
Please do. Please do.
So the aspirin situation is tricky, as Pablo alluded to. Obviously, people that have a history of heart disease or stroke or that type of thing, people that have had stents, people that have had heart attacks, these people should be on aspirin. There's a lot of people out there, though, that don't know if they have heart disease or not. 30% of otherwise healthy people actually have atherosclerosis. So if you take 10 people off the street and screen them with, say, calcium scoring, 30% of them will have plaque in arteries. So they will have risk of heart attack. That means 70% won't. That's why the old strategy of putting everybody on aspirin once they were 60 or 65 was not good, because 70% of people didn't need them. People can have all those complications like Dr. Rengifo was talking about, like bleeding and things like that. And the risk outweigh the benefits when 70% of the people are getting something that have risks that they don't need and only 30% need it. But if you don't give aspirin to any of those 10 people, then you're getting those 30% that would have some risk reduction with aspirin that aren't getting the benefit. So that's where screening is such an important thing. And that's where these things like we talk about calcium scores and some of these other things that we can provide in the community being very crucial for making sure that these medications are, and it's aspirin, it's cholesterol medicine, it's all these things that once you've identified risk, these things that we use to mitigate that risk. And we want to make sure we use those in the appropriate populations, because just remember that 50% of heart attacks, including people that didn't previously know that they had heart disease. So this is the person with their first heart attack even. 50% of heart attacks present not as chest pain and go to the ER. 50% present as sudden death, CPR, defibrillator, or somebody dying in their sleep. So that's the stakes that we're talking about of not knowing. So that's why I think aggressively screening is such an important thing.
So bottom line, talk to your doctor before you pop an aspirin for this on a regular basis. Okay, assuming that all the prevention fails and you end up having to go into surgery, Dr. Murrah, what questions should patients ask their surgeons before they go into when they go into the consultation, before they go forward with surgery?
You have to understand it's a very intimidating thing for patients to come and talk to a surgeon. They are entitled to learn about the risks, benefits, and alternatives to any procedure. So that's part of the informed consent process. And that's such an important thing that they get their questions answered. So the risk, benefits, alternatives, very important. I think it's important when I see a patient, they look at me and say, okay, is this a guy that am I going to trust him or her to operate on my heart? Is this a person that I think is the right person for that? And what is your experience level? I've developed some gray hair over here, so that's helped me some. For a while there, didn't have any, but that helps. But just really having, and like anything else, as you do more and more, you become better. And I think the experience level, they are certainly entitled to ask, how many of these have you done? What have been what are the complications that are going to happen with me? And so they're not surprised when things happen. But just so having a good surgeon that talks to them about all the risks, benefits, and alternatives, I think it's really important in the experience of the surgeon. But they're going to get their questions answered one way or another. I like to do it up front.
Well, that's good to know. When patients hear heart surgery, though, they think about open heart surgery. That's what comes to my mind first. But we've gone beyond that, right? I mean, not that it's not necessary, but talk about the way that heart surgery has evolved a bit.
Right. I think what's interesting, just looking at this webinar, I think Greg has probably said the most, and Greg's kind of about the prevention, medical therapy, and imaging as well. Does a great job with that. He's probably said the most. And I think that is proportional to the importance of that in cardiovascular disease. And then you go see Dr. Ringifo or Dr. Knoll or his colleague, Dr. Vargas and Dr. Dixon, in interventional cardiology, and there's options there. And then you come see me as the last guy. But it is really, but again, I think the thing that's really different these days, that there's a lot of crossover. I think the fascinating thing that's really exciting to me is I enjoy the what we call a TAVR. It's the transfemoral aortic valve replacement that we do. And we're getting into the mitral realm, tricuspid realm. And these are patients that, and as the population has aged, these are really high risk patients that we older heart surgeons, which I will count myself as one of those now, remember having to do those. There's no other option for those people. They were in for a long time in the hospital. It is fascinating and incredible how well they do on our what we call our TAVR Tuesdays and sometimes other days. So that's an exciting thing. That's a way we're avoiding open heart surgery and doing sternotomy. Things we're doing surgically that are really fascinating is we're intervening sooner in mitral valve disease and doing complex mitral valve repairs. That's an important thing that is also experience dependent, and we bring a great deal of experience here in mitral valve repair. I think that's very important. I think in Dr. Ringifo and the interventional cardiologist world, I think also avoiding surgery, what we call high-risk PCI, percutaneous coronary intervention. There are patients that may have in the past we were forced to operate on. Now we have devices that we can use, and there's the latest device called an Impella that helps us to support the heart while high-risk interventions are done, non-surgical interventions are done. So there's some people that have a lot of, people are 80, 90 years old now coming in with what would be surgical disease otherwise, who really can't tolerate a big operation. So we are the mindset to try to avoid that if possible. And we have a lot of great options for non-surgical approaches to disease.
Okay.
And again, a team like this can't overemphasize team approach.
Okay, but there will still be some people who are going to need open heart surgery.
Oh, there's plenty to do, plenty of work, yes. But we try to exhaust all non-surgical options. If you give a patient a choice, they're not going to want to be opened up and have us work on them. So, and we like to give them all the good options.
Okay, let me go to Dr. Hartledge, and I'd like to talk a little bit about, you specialize in cardio-oncology, or I mentioned that earlier. Why might someone who has had cancer need a cardiologist as well?
Well, there's a number of different reasons that have to do with, number one, just the prevalence of these cardiac conditions that can be exacerbated during a cancer diagnosis and treatment. People that have cancers are often more prone to clotting, so they can actually be more likely, if they have underlying heart disease, to have a heart attack during that time. They're also prone to have anemia and things like that can also exacerbate heart disease, where they don't have enough blood cells going through the body. And there is the actual treatment of cancers that involve often chemotherapy that can be toxic directly to the heart, sometimes toxic to the heart muscles, sometimes can cause problems with the coronary arteries like spasms. Some of these medications can make people more prone to clot. Some of them can cause heart rhythm abnormalities. So we have not just the patient-related characteristics, the treatment-related characteristics related to the chemotherapy and other targeted cancer therapies. A lot of these newer biologic agents that are safer than a lot of the older, really toxic chemos because of the biologic mechanism with which they work. They can affect the heart muscle, sometimes causing a heart to get weak or things like that. And then the other big, outside of surgery, the other big traditional and current cancer treatment is radiation therapy. So anything that involves the chest, lung cancers, particularly on the left-sided breast cancers, or people that had lymphomas or things like that, where they had to have radiation inside of their chest of a tumor. If the heart's in that field of radiation, then every part of the heart can get affected by radiation. The arteries can be affected. That's another form of how arteries can be damaged, like we talk about all the other more common things in terms of traditional risk factors. Radiation is a more non-traditional risk factor, but it really can cause accelerated atherosclerosis. And it can cause heart valve problems, and it can cause problems with the heart muscle and problems with the lining of the heart and all kinds of things. So radiation, there are some things that can happen within a few months after radiation, and then a lot of things that 5 to 10 years later, when somebody was otherwise cured from their cancer, they can have something pop up like a new heart murmur or a blockage or something like that was actually related to their radiation therapy 5 or 10 years prior. So
And that's where
there's historical elements like that.
And that is where a cardio oncologist would have the upper hand as opposed to.
So as cardio oncologists, we work with the oncologists and hematologists, the cancer doctors, and the cancer center, and we have a program where, based on certain cancer diagnoses and certain cancer treatment modalities, that we see these patients, as well as them seeing the oncologist, they see us, and we keep an eye on certain things related to the heart, whether it's the heart muscle or heart rhythm related things specific to drugs that can be toxic to those different parts of the heart.
And
Can I go ahead,
Greg? I mean, just to your point, I'm not a specialist in cardio-oncology. It's mostly run by Dr. Harlech and Dr. Rayatsada. But you can even identify now with new modalities in ultrasound and with MRI, changes that are so subtle that maybe 20 years ago we couldn't identify. Now you can identify even before they have a phenotypical, if you would, characterization in an ultrasound. Before the EF drops to 30%, you're starting to see some changes with strain and other modalities in ultrasound.
Yeah, so what strain imaging is it allows us to look at the sort of microscopic level of contractility of heart muscle, not the macroscopic level, which would be looking at the layer of heart muscle on the ultrasound and how it pumps. What we're able to look at is more on the fiber level in different regions of the heart and globally in the heart, how vigorously the fibers on a more microscopic level. And that microscopic, or we call it strain imaging, because it looks at the way that the fibers contract, and they actually get shorter when the heart muscle contracts. And we can see when that starts to kind of loosen up and the heart muscle is at risk of having a clinical dysfunction, meaning the ejection fraction would drop, and then people start retaining fluid and go into heart failure and that type of thing. And that's the worst case scenario in terms of cancer treatment, because if you get to that point where the heart muscle is affected, it's gotten weak and people are retaining fluid and heart failure, you have to stop the chemo. All right. And that's the worst thing when you have cancer, is to have to stop your chemo, because you won't get the benefit of it if you're not taking it. So what we look for in the cardio-oncology echo protocols using the strain imaging is to see if people that are on these potentially risky type of protocols of targeted cancer therapies to see if they demonstrate that early sort of subclinical microscopic cardiac dysfunction. And then that gives us a window of opportunity to start preventative heart medicines that will allow them to stay on their chemotherapy and on their cancer treatments without having to have interruption. So that's the whole idea, is to protect the heart so that they can also get the benefit of their chemotherapy.
Yeah.
Can I make a quick plug just to
Yes, of
reemphasize
course.
as a heart surgeon looking in on it? You know, cardio-oncology is a new field, and we've got it here, and we're really on it. We have 2 cardio oncologists here, and we're really proud of that. It's a growing field, and we're basically on it.
That's good to know. Okay, no discussion. We're getting kind of close to the end here, and no discussion will be complete without talking about COVID, because it's COVID. And there's a lot of talk about how the COVID it can impact the heart. Dr. Rengifo, what do we know so far about COVID in the heart?
Well, it's an evolving topic, but in general, the virus itself can affect the heart muscle. And when the heart muscle is infected or is inflamed, we call it myocarditis, and produces some systolic dysfunction. Systolic meaning the pumping of the heart at that point. Apart from that, when you have COVID, and we're talking about bad cases of COVID, you have problems with oxygenation. The heart muscle is very susceptible to lack of oxygen. As in a heart attack, it's toxic for the heart to be in an environment deprived of oxygen. So also you can have inflammation of the vessels that are supplying blood and oxygen to the heart muscle, like in ischemic heart disease, that will produce not only systolic, meaning the pumping, but also diastolic, meaning the relaxation of the heart and the filling with blood. So those are 2 different mechanisms. On top of that, the heart can experience stress, what we call stress cardiomyopathy, which increases of catecholamines at the moment that the patient is going through the COVID infection, and that can help affect the heart with systolic, meaning pumping dysfunction that can be transient, but in a moment of critical illness can produce changes that might not be something that will recover completely. On the other hand, there's an defense mechanism, an immune mechanism that's going on in COVID. Sometimes it's exaggerated. So this produces inflammation that is out of proportion to the infection and can affect the heart. So what patients can experience long-term is weakness of the heart, which we call heart failure, where you collect fluid that you cannot get rid of, and that's a situation where you develop shortness of breath, and it's potentially deadly. There's another component of COVID, which is there's a hypercoagulable state, meaning you are forming clots in an exaggerated manner, and that can lead to ischemic heart disease, meaning lack of oxygen because you're obstructing blood vessels, but it also can produce what we call pulmonary embolism, which is clots at the level of the pulmonary arteries, which are the ones that communicate the right side of the heart with the lungs, where blood is going to go to receive oxygen and then be pumped to the rest of the heart. So there's many ways that COVID can affect the heart and the body. It's all connected, so it's not something that you can say it just affects this way, but it's inflammation, immune response, lack of oxygen, inflamed vessels that can lead at the end to pump failure, if you will.
So if you have had COVID, you should let your primary doctor know that, because if you're having any issues,
it could be a consequence.
it
Will be, but it will be rare. We have to say this, it will be rare. This is of the exception, not of the rule. But yes, your primary care physician and you have a cardiologist should know about it.
Okay, that's good advice. Okay, this is the last question because we're coming to the end of our time here. This is a viewer question, does 70 to 75% blockage require bypass, even if you're not having any symptoms?
Defer.
Who wants to take a stab at it?
Well, 70 to 75% blockage. It all depends on the territory that the artery is supplying. I mean, if you see that the coronary arteries are like a tree, you have the main stem and then you have branches. So if you have 75% in a tiny vessel, in a tiny branch, probably that's going to be something that is not going to produce you any trouble, even if it completely occludes in the future. Not the same thing if you have what we call the left main, which is the origin of the left coronary artery, is the very beginning, and it gives a big proportion of the heart muscle. To have a 75% lesion there should be studied. If the patient is asymptomatic, there's testing that we can do to understand its significance. I would say one of the questions before, some people see exercise not only as something to prevent heart conditions, but if you're exercising every day, like my colleague, Dr. Hartlich, he likes to run. If you're running every day 2 miles, that's not going to be different from a stress test. You're stressing your heart all the time. So if you're running 2 miles every day and we found a 75% lesion in one of your arteries, we might not treat that. But if you're somebody that is sedentary, doesn't move, doesn't do much, is in the computer all the time and has a 75% lesion, we are going to be more aggressive into provoking not symptoms, but what is physiologically significant, meaning what is affecting the circulation and the blood flow in the heart muscle. Okay. So that question doesn't have a straight answer. It all depends where it is, how active are you, and so we will do that assessment.
Okay, so again, we have to ask our doctors. Okay, well, we are about out of time here. I want to let folks know, if you've signed up for this, that you will receive, we're going to receive the video. It will, we'll send this video out and answer a few more questions in an email if you have any. So I've learned a lot here tonight. I'm really glad you guys were here. Let's see here. We've got, I'm just going to have to thank you all. I'm being told that it's time to. So thank you all so much for your time and your expertise and sharing it with us. And thank you to the viewers who tuned in. I hope you learned something as well. I know I did, and I hope you enjoyed it. For more information on heart services available at TMH, you can visit tmh.org/heart. Everybody, have a great night. Thanks so much. Take care.
Thank you. Good night.
Thank you.
Thank you.